Hi, my name is Dr. Flam. I'm the medical director for Lifeline Critical Care Transport, and I'm here today to discuss with you pre-hospital ultrasound, past, present, and future. This is the opening lecture for our eFAST lecture series. So thank you for joining. I have no disclosures or conflicts of interest. So in this presentation, I'd like to discuss how ultrasound can be used in the emergency department and suggest how ultrasound can also be used in the pre-hospital setting. We'll kind of give examples for clinical scenarios and discuss the literature a little to support what we're discussing. And we'll also go on to a discussion of where we go from here. So ultrasound in the emergency department. It's widespread, there's widespread use of ultrasound in emergency departments. Applications are really broad and include eFAST for trauma. We look at cardiac motion. We look at resuscitation. In resuscitations, we look at IVC, cardiac squeeze. We evaluate patients with respiratory distress for pneumonia, CHF, effusions, pneumothoraces. We also evaluate patients with abdominal and flank pain for AAAs, for renal, gallbladder, and urinary retention. In OB emergencies, we look for IUPs, ectopic pregnancies in free air and free fluid. We conduct direct visualization with procedures, for example, central lines, peripheral IVs, arterial lines, thoracentesis, paracentesis, peritonsillar abscess, pericardiocentesis, and also abscess identification. We evaluate patients for DVTs, and we also use it, and this is a new one, for endotracheal tube conformation placement. So, as you see, ultrasound is frequently used in the emergency department for a wide array of studies and treatments to evaluate vast different, a broad number of chief complaints in patients. So, how can we use it in the pre-hospital setting? So, one thing that we want to do in the pre-hospital setting, and now it's all drilled in really well, is we want to stop the bleed. If we see someone with an active bleed, we're going to stop the bleed. And it might be direct pressure, we might be packing a wound, and we might be even placing a tourniquet if needed. But what if the bleed is internal? So if someone has an internal bleed, we all know that the definitive care is going to be a surgical intervention in the operating room. And the earlier we identify these type of patients and get them to a center where they can receive definitive care, and the faster we do it, the better survival they have. And that's what the ATLS has been teaching for many years, and and the PHTLS too, and we're all very aware of that. So you may be wondering, how accurate is ultrasound to identify intra-abdominal bleeds? So in fact, there have been multiple studies, over 10 studies that look at the test. And what these studies found is that the sensitivity varies. It's somewhere between 40 to 90 something percent. But the specificity is between 95 to 99%, meaning if you identify a positive FAST, it's pretty likely that the patient has free fluid in the abdomen. But if you have a negative FAST, it doesn't say as much, it says less. It doesn't guarantee there's no free fluid. So it's very good for a test that you can come do pretty fast, no pun intended. And if you identify free fluid, you can say, well, this patient has free fluid. Now, don't forget, if someone has free fluid in the abdomen and low blood pressure, that's an indication to go to the operating room directly. And that will actually change management. So that's where you have a great impact on patient care and on management. You can also identify free fluid around the heart. And sometimes a patient will be hypotensive. It's really hard to figure out why. And finally, when you put the ultrasound on the heart, you're going to figure out that there's free fluid around the heart, and that's what's causing the tamponade. We all know the treatment for tamponade is going to be to bring a patient to a medical center where they can get an emergent pericardiocentesis to pull off that fluid around the heart and reduce the strain on the heart. Now, how much fluid can we even recognize in the abdomen? That's a question you might be wondering. Well, if someone has a small bleed, can we still recognize it? So the answer is there have been about 4 or 5 studies that look into this, and the answer is around 200 mLs, which is pretty good. A DPL, which is the test where you inject fluid into the intra-abdominal cavity and then draw it back and see if there's blood in the fluid, can recognize 20 mLs of fluid, but we don't really do it anymore. It's kind of fell on the wayside with the advent of the CAT scan and ultrasound. A CAT scan can identify around 100 mLs. So the ultrasound is a little less sensitive than the CAT scan at volumes it identifies, but still pretty good, because if someone has less than 200 mLs in their abdomen, it's a relatively small amount. In terms of lung sliding, because we're talking about eFAST, there is very high sensitivity and specificity for identifying lung sliding. The sensitivity is 97% and specificity is 94%, meaning if you see lung sliding, it's unlikely to have a pneumothorax. If you don't see lung sliding, very high likelihood still that the patient does have pneumothorax. And when we compare that to chest x-rays, I'd like to remind you that a chest x-ray has a significantly lower sensitivity and specificity for pneumothoraces. So, for example, auscultation is somewhere around 50% for detecting pneumothorax, meaning half the time you may detect it, half the time you won't. And of course, on a helicopter, it's 0% because we can't listen on a helicopter because of the noise. Chest x-rays have somewhere between 30 to 70%, 75% sensitivity, meaning, 25% of the time out of luck. And our ultrasound is in the high 90s, meaning the ultrasound actually provides a higher sensitivity than a chest x-ray. How fast does it take to do an ultrasound to identify pneumothorax? So, well, you may wonder, how long does it take to get a chest x-ray? So on average, and this is a good average, I don't know where they measure these averages, it was 7 to 12 minutes. So they're pretty fast wherever they were doing this. And with ultrasound, it's 1 to 2.3 minutes, way faster with an ultrasound. So hopefully I convinced you that for pneumothoraces, an ultrasound is superior to a chest x-ray, which you don't even have in the field, by the way. And now suddenly we have a device that can give us better results than a chest x-ray. Now, can ultrasound actually impact patient care? Can it change our decision-making in the field? So there have been a number of studies that examined exactly that. And the long story short is that it was found that using an ultrasound in the EMS setting can indeed change management and change and impact decision-making in the field. There's a big study going on in, I believe, New Mexico, where they gave paramedic supervisors an ultrasound and they asked them to do a cardiac ultrasound, this to evaluate for cardiac squeeze in patients with PEA arrest before they were pronounced in the field. And what they found was that they had a few patients that they thought were in cardiac arrest. They couldn't feel a pulse, even though they had PEA on the monitor, or electrical activity on the monitor, that is. And they found that with ultrasound, they actually recognized the patients did have cardiac motion, and they continued to take them to the hospital and provide care. And a few of them actually survived. So it can help us actually this is a life or death thing. It can help us not miss people that have a potential to survive in cardiac arrest. Isn't that great? So in summary, ultrasound is used frequently in the emergency department. And But many will argue that it's time to bring it out to the field and start using it in the field. There's good evidence that it's sensitive and specific for identifying pneumothoraces. It's pretty good at identifying free fluid in the abdomen, especially in volumes over 200 mLs. And there really isn't a lot of downside to using ultrasound, as long as we don't delay the patient's care and transport to definitive care. We do it on their way. If you have an unstable patient, don't stay in the field and try and start doing ultrasound in the field, delaying their transport. That's a big no. As long as we expedite their care like we would anyway, and we do all the ultrasound tests on the way to the hospital, we can actually get good, valuable data that I believe in the future will also impact patients' care. For example, on the way to the hospital, if you find a positive FAST and you have a hypotensive patient, you may be calling a trauma center and telling them, giving them this information, and they may direct you to go straight to the operating room rather than the trauma bay so the patient can get definitive care timely. And that's where the use of an ultrasound and an eFAST will save patients' lives. So thank you for listening to this introduction lecture. We have a few great lectures ahead that discuss how to do an eFAST ultrasound. We're also going to have a hands-on component where we'll work with you hands-on to obtain and interpret FAST exams. A few great ultrasound resources out there are ultrasoundpodcast.com, 5minsonos.com, thepocusatlas.com, highlandultrasound.com, sofsono.org, ultrasoundeducation.com, check out foamfrat.com. It's a good foam resource for ultrasound and medical education. And a few thank yous. I'd like to thank Dr. Cynthia Griffin, who's a flight physician out of MedFlight, for sharing her slides, her knowledge, and all the work she's done in this field. She's a pioneer in the field of pre-hospital ultrasound, so thank you for that. I'd like to thank Dr. Tom Carroll from WellSpan New York Hospital for teaching me everything I know about ultrasound. He was my ultrasound director in fellowship. In residency, sorry. I'd like to thank Dr. Alicia Buck and Allison Leon from the University of Florida EMS, who shared their ultrasound slides and work with me. I'd like to thank Dr. Steve Moore, who's emergency medicine, critical care, and was the ultrasound director at Hershey Medical Center while I was here for a few years until he moved to Hawaii. And he helped me with my ultrasonographic endeavors at Hershey Medical Center. I'd like to thank Dr. Susan Promise, my chair, for supporting my ultrasound interest and research, helping me find funding to purchase the ultrasound machines we have, and supporting the research we do in EMS. And final but not least, I'd like to thank my Lifeline team and the research team from our med school, who have put a lot of time and effort into this study. And you'll hear from them in the upcoming videos. They will teach you a lot of great things about eFAST and ultrasound. And they will also teach you how to do ultrasound hands-on. So stay tuned. Thank you very much, and to be continued.